Hello, everyone. I'm Daniela Filipescu, WFSA President, wishing you all a happy World Anesthesia Day 2025. This day brings our global community together to celebrate progress and recognize the vital role of anesthesiologists in safe, affordable emergency care. Our 2025 theme, Anesthesiology in Health Emergencies, highlights how essential we are in crisis, often on the front line, providing life-saving treatment. WFSA work on this year's annual theme includes focus statements at WHO meetings, new educational resources such as a new tutorial of the week package for health emergencies, a special update in anesthesia issue, and a series of webinars held over the year and also happening today, a chance to learn, connect, and share. Join the webinars. Share your stories through the dedicated photo booth and In Your Shoes campaign, and help us make the World Anesthesia Day 2025 unforgettable.
Hello friends, I'm Sheila Myatra, Chair of the Intensive and Critical Care Medicine Committee of the WFSA. Welcome to the WFSA Marathon session. We have 4 focus webinars with lectures and interactive panel discussions, highlighting the pivotal role of anesthesiologists in managing health emergencies from disaster response to critical care crisis. The sessions will explore preparedness, rapid decision-making, resuscitation expertise, and leadership of anesthesiologists as part of multidisciplinary teams in various health emergencies, underscoring their indispensable role in saving lives when seconds count. Thank you for joining.
Good afternoon, everyone, and welcome. It's a real pleasure to have you all with us for this special WFC webinar, held as a part of the celebrations of the Anaesthesia Day 2025. My name is Joao Silva, and I'm dealing to serve as one of your chairpersons for Tuesday's sessions. Our focus at that moment is a topic of critical importance for all health care professionals: cardiorespiratory support in health emergencies. I'd like to extend a very warm welcome to my co-chairpersons, Dr. Annie Crawford, Dr. Divatia. GV will be guiding us through the speaker's presentations this afternoon and to get us started. I will now hand it over to him to introduce our first speakers. Divide, be my guest, please.
Good evening, everyone. Welcome to this webinar and greetings on the occasion of World Anesthesia Day. So we will have 3 lectures followed by a panel discussion. So the first talk will be on the latest CPR guidelines. The second one will be on tracheal intubation in the critically ill. And the last talk will be on non-invasive respiratory support and acute hypoxemic respiratory failure. And these will be given by Dr. Bernd Böttiger from Germany, Dr. Sheila Myatra from India, and Dr. Samir Jaber from France. Following the lectures, we'll have a panel discussion, and the 3 speakers will be joined by 3 panelists. Can I have the next, please? So remember, you can give the QA, question and answer. You can submit them on Zoom via the Q&A tab. You can also put it in your language and it'll be translated. And this recording will be published on YouTube and a link will be sent to your registered email. So to introduce our speakers, we welcome Dr. Bernd Böttiger. He is a professor and former head of anesthesiology at the University of Cologne. He's a federal medical advisor for the German Red Cross and the chairman of the German Resuscitation Council. He has held major national and international resuscitation initiatives. And as I understand, he's about to speak to the German Parliament. So welcome, Dr. Böttiger. Next, we have Dr. Sheila Nainan Myatra. She's the Professor of Anesthesiology and Critical Care Medicine working at the Tata Memorial Hospital in Mumbai, India. She's the dynamic and efficient chair of the Intensive and Critical Care Medicine Committee of the WFSA. She's a past president of the Indian Society of Critical Care Medicine, and she also holds important positions in the Indian Society of Anesthesiologists. She's a board member of the Global Sepsis Alliance and a member of the World Health Organization Acute Care Network. Our third speaker is Professor Samir Jaber. He's the head of critical care and anesthesia of the St. Eloi University Hospital in Montpellier, France. He's a past president of the Scientific Council of the French Society of Anesthesia and Critical Care, and he is the editor-in-chief of Intensive Care Medicine, the journal. Prof. Jaber has more than 600 peer-reviewed articles, and his interests include sedation, obesity, acute respiratory failure, ARDS, non-invasive ventilation, and mechanical ventilation. We then have three panelists. So we welcome Dr. Faye Evans from the US. She is a senior associate professor in perioperative anesthesia in the Department of Anesthesiology, Critical Care and Pain Medicine at the Boston Children's Hospital, and an associate professor in anesthesia at the Harvard Medical School. She focuses on improving the quality and safety of anesthesia in low and middle income country settings through education and advocacy. We have Dr. Suneerat Kongsayreepong from Thailand. She's a professor of anesthesia at the Suneerat Hospital, Mahidol University, and she's got experience in cardiac pediatric critical care from the Mayo Clinic and Harvard. She's a past president of the ASPA, the president-elect of the Thai Society of Critical Care Medicine, and serves on the WFSA Intensive and Critical Care Committee. Our last panelist is Dr. Daniel Talmor from the US. He is the chair of the Department of Anesthesia, Critical Care and Pain Medicine at the Beth Israel Deaconess Medical Center and the Edward Lowenstein Professor of Anesthesia at the Harvard Medical School. His interests are centered on early identification and treatment of critically ill patients, with particular focus on optimal delivery of mechanical ventilation and landmark trials in the field of ventilation and ARDS. So with this, I think we can move to our next talk. And before that, a reminder that we will be having the World Congress of Anesthesia at Marrakesh in April next year. So can I now request Dr. Bernd Böttiger to speak on new advances in cardiopulmonary resuscitation?
Yes, thank you very much for your nice introduction. I have just shared my screen, and it's a great pleasure for me to speak to you today. So thank you very much for the invitation. The latest CPR guidelines, what is new? The problem is, okay, now it's coming. The problem is that they will be published on October 22nd, and I'm not allowed to speak about, but I can give you some insights what is expected. 15 minutes is a challenge because they have nearly 1,000 pages, but I will try. And the focus is on the first 3 to 5 minutes. I mean, we are anesthesiologists, and resuscitation is key part of our specialty. That is, by the way, why today it's not only World Anesthesia Day, but it's also World Restart a Heart Day under the umbrella of the International Liaison Committee on Resuscitation. And we know that the brain starts to die within 3 to 5 minutes, and that's the reason why the focus is here. Sorry, that was a little bit too fast with my conflict of interest. I'm engaged in several organizations nationally and internationally. And as you can see here, sudden out-of-hospital cardiac arrest is the third leading cause of death in the world, at least in mid-sized and developed countries. Nearly as many people die of sudden out-of-hospital cardiac arrest as of cancer. That is impressive. And in Europe, we have 2 jumbo jets crashing down every day, all over the year. 1,000 deaths by out-of-hospital cardiac arrest in Europe. And the same applies to the US, to South America, to Asia, to Australasia, and to many other countries. So what is most important? If the brain has no oxygen anymore, you must pump blood. In the rest of the body, there is enough oxygen, but not in the brain, because the brain is consuming so much oxygen. So in the first minutes, it is enough if you start the circulation again by 2 hands. You only need 2 hands to help the bloodstream flow to the brain. And that, again, here, the focus is on the first 3 to 5 minutes in the new guidelines. And as you can see here, if someone is collapsing, the EMS in my country is coming after 9 minutes in median, but sometimes it's much later. And the problem is the brain dies after 3 to 5 minutes. So the emergency medical service more or less always are coming too late. That's the reason why less than 10% of the third leading cause of death survive during these days. And there is one way how we increase survival very much. This is someone need to bridge the time until the EMS is coming. So lay resuscitation is important. And you probably know the chain of survival, but I'm not sure whether you know this chain of survival based on real data showing that early recognition and call for help and early CPR is much, much, much more important than defibrillation or post-resuscitation care. So if the patient is not resuscitated early, we are with empty hands. We do not have any drugs to save the brain or to improve neurological function after cardiac arrest. So lay people all around the world need to know if you wait for the ambulance, the brain will already be dead. And we can take Denmark as a blueprint, but also other countries. I will come to that later. They started a national initiative some years ago, and they started with a very low bystander CPR rate. So bystanders started CPR before the EMS was coming, and they increased it over the years. They are now above 70%, and they started at 20%. And what they did, mandatory education of school children in CPR and many other things. This increased bystander CPR rate, and look at this. Survival following out of hospital cardiac arrest, survival rate was tripled, 300% more survivors due to this national initiative. This is much better than anything in any other deadly entity. We are speaking now, if we extrapolate this, about 300,000 lives in our whole world. And what they did was check, call, compress. That was the message. Ventilation is not absolutely necessary in the first 10 minutes. Check for signs of life. Call the emergency number. In most of the countries, it's 112. And start pumping blood again to the brain. In the rest of the body is enough oxygen. I already said that. You only need to take over the function from the heart. This is a global blueprint to increase survival. And this is also what is focusing on in the old guidelines from 2021. As I said, I'm not allowed to speak about the new guidelines, but I can promise the chapter on system saving lives will be the key chapter in the new guidelines, because this is the way how we really can save a lot of lives. So I will take this as an example, what you can expect from the new guidelines. And in the new guidelines, this guy will probably play a key role. It is the dispatcher. The dispatcher's role is very, very key in the new guidelines, and I will show you why. The focus is on the first 3 to 5 minutes, and we need the dispatcher to identify the cardiac arrest and to help via telephone or video-supported CPR the lay people to do the right thing. And these 5 things are most important key things in the System Saving Lives chapter. Raise awareness about CPR and defibrillation in the public. Think about the first rings of the chain of survival, 3 times more survivors with lay resuscitation. That's the reason why we are doing World Restart a Heart since 2018 right now. And this is the logo of World Restart a Heart. And I'm sure many of you have already been participating. We are present in 192 countries. This is nearly all countries of the world. Only 2 are missing. And since 2018, we have trained nearly 600 million people, or we have reached them at least via TV and social media. Next thing is use technologies to encourage communities, which means install a first responder system in your community. First responders are people that are nearby a cardiac arrest and are alerted via their smartphone. In 50% or more, first responders reach the victim within 3 to 5 minutes, and that's the key time window. Again, the focus is on this time window, and this is a map of Germany. And in Germany, we have been successful in at least establishing first responder systems in 50% of the whole area of the country. Number 3 of the system saving lives key things is educate school children in cardiopulmonary resuscitation. In every family, you must have a lifesaver. That is our goal and our vision. And therefore, you need to start in schools. It should be like driving a bicycle or playing an instrument or swimming. If they learn it in school before puberty, they do not forget. By the way, if we are training school children, and also today here in Stuttgart, we have a blue sky and the sun is shining, which is in my eyes a signal from the sky that we are doing the right thing. We are also supported since 2015 with this Kids Save Lives initiative by the World Health Organization. And this is a map of Europe. And you can see in 6 European countries, upon our initiative, education of school children in CPR is mandatory by law. And in 24 other countries, it is at least a suggestion. We have published in circulation a systematic review in children and school children education in CPR last year, which was accompanied by a press release from the American Heart stating learning to save lives can start as early as 4 years. This press release went in 80 countries, and our suggestion for kids is 2 hours training per year. Start in the kindergarten, they can check and call. They cannot compress, but they understand what compression is, and they can explain it to an adult who does not know it. And with 10 to 12 years, they have enough physical power also to compress. And we educate them in ventilation and AED when they are a little bit older during puberty. But the most important thing is check, call, compress. You can bridge the time until the EMS is coming with very simple measures. You only need to have 2 hands, and you do not need to ventilate in the first minutes. In Europe, the European Resuscitation Council has Kids Save Lives in the guidelines since 2021, and I can promise it will play an even larger and more impressive role in the new guidelines. People after out-of-hospital cardiac arrests should not go to the next hospital, but they should go to a so-called cardiac arrest center, because in more than 60 or 70%, they have a coronary problem, and this coronary problem needs to be solved within the first 60 to 90 minutes in the cardiac catheterization lab. So cardiac arrest centers are important. They improve survival by 2 times. We have many systematic reviews on this. And this is the German map of certified cardiac arrest centers. We are the first country with a nationwide certification process for cardiac arrest centers. And this can also be a blueprint for the whole world. And I'm wondering whether you still know what this is. If you ask children, they do not know it at all. This is about the 5th thing, which is important. It's dispatch-assisted CPR. And you see the guy from the dispatch center down there again. Telephone CPR, number needed to treat is 7. So people should not stop the phone call, but they should put the phone on the loudspeaker, and then the dispatch center is sending the emergency car and will explain people on the phone. You can do it within 1 minute how to do chest compressions, and that needs to be spread all over the world. Telephone CPR. This is again focused on the first 3 to 5 minutes. In Lübeck, this was done about a year ago, and a 10-year-old was instructed by the dispatcher how to do CPR on his father, and his father survived. So this can easily also be done by young people. And what do these 5 animals doing in a talk about the new guidelines on cardiopulmonary resuscitation? What I have shown you right now is the big 5 in resuscitation. And this is much, much more important than any drug or anything we can do in the intensive care unit. This is much more important than cooling or not cooling, or all these discussions we have. This is the big 5. We had a very early publication on this. And at the end of my talk, I would like to focus also on hypothermia, because we have a huge discussion whether we should use hypothermia or not. And this discussion is because of the new TTM1 and TTM2 trial. I don't have the time to focus on this trial here, but what I can show you is there are patients where TTM or where hypothermia is absolutely necessary, at least in my eyes, and there are patients where it does probably not help. And you can see here on the x-axis the rate of bystander CPR, and on the y-axis the additional benefit per 1,000 patients by hypothermia. This is the bystander CPR rate. And as you can see here, TTM1 and TTM2 trial with bystander CPR rates of 70 and 80%. So they do not really had a cardiac arrest. So the blood flow was immediately installed by lay people who were bystanders. In that case, hypothermia does not really work, which is not surprising to me because the brain does not have a severe insult. But if you have lower bystander rates, like in my country, 40, 50%, or maybe in many countries we have bystander rates less than 20%, there hypothermia works, and this has also been supported by a Cochrane review published last year. So these are our patients, low bystander CPR rates. That's the reason why we are cooling for 30 degrees Celsius for at least 24 hours. What else can be expected on October 22nd when the new guidelines will be published worldwide? And the good message is many things will stay stable. So the use of epinephrine defibrillators, there's not so much new, but what is already recommended, and I mean we are all specialists in resuscitation, will remain stable. That's nice. We will have nice new pictures and algorithms that you can print out and put in your OR and intensive care unit. Successful ventilation by emergency medical service. I will show you in a minute a key study. This is really a key issue, which is also pointed out in the new guidelines. Also sedation during CPR in selected patients, because some patients will become, if you're doing good CPR, they will become awake during ongoing cardiac compressions. And if you stop compressions, they become unconscious again. And also advocacy and legislation. I'm in the parliament right now to educate members of the parliament in a few minutes in CPR, and to have their support. Legislation is a key issue. I will show you a study on this. For sure, social media and AI will probably play a role as co-survivors. The chapter on special circumstances is extended. After a study in UK, Reboa is not recommended anymore as a routine approach in trauma CPR. And overall, normoxemia, normal blood pressure, normocapnia are important. Echo and ECMO in selected patients. We also focus on CPR in low resource settings and on many other things. And the focus is on the first 3 to 5 minutes. And the most important, in my eyes, 2 key studies that informed the guidelines I will show you at the end of my talk. Back valve mask ventilation. As an anesthesiologist, we know how difficult this is. Maybe intubation of the trachea is more important, and many EMS providers cannot be trained in the OR. As you can see here, a retrospective study focusing on thoracic impedance detected by the defibrillator that was attached to the thorax of the patient during the first 10 minutes of 32 CPR before they introduced a supraglottic airway device or a tube. And they had 2 groups. In one group, they had 12 pauses and 2 ventilations in 10 minutes. And in the second group, they had 12 pauses and 12 ventilations per patient in 10 minutes, detected by thoracic impedance. In 10 minutes, you need to have 60 to 70 ventilations. So this is reality some years ago in America, in American EMS, and I'm sure this is reality worldwide. And this has a huge impact on survival of the patients, because if you had at least 12 ventilations in 10 minutes, survival rate was 4 times higher than in the group where you only had 2 ventilations, which is no surprise to me. So we need to train our EMS providers in ventilation. They need to really detect successful ventilation because this can increase survival rate by 4 times, which is again much more important than any other thing. Ventilation by back valve mask is difficult, and we need to improve this. This study will change a lot. And last not least, if you do a legislation like we have seen from Denmark, in China, they did the same. They started at a very low level of cardiac arrest survivors. And after legislation on educating lay people and school children in CPR, they detected 5 times more survivors So this is the CPR, bystander CPR rate before and after legislation. This is the survival rate. This is better than anything else to help to save hundreds of thousands of lives worldwide. We do need legislation all over the world. Focus on the first.
It only takes 2 hands to save a life.
That's my final message.
It only takes 2 hands to save a life.
From Rio de Janeiro, where we are training children from favelas. So thank you very much for your attention.
Thank you, Dr. Böttiger. We'll now move on to the next talk by Professor Sheila Nainan Myatra.
Hello, everyone. I'm going to speak on tracheal intubation in the ICU, life-saving or life-threatening. I hope by the end of the presentation, I'm able to justify the title. I have no disclosures for this presentation. I'm going to start with a case. 57-year-old male, acute hypoxemic respiratory failure, comes to the intensive care unit, delirious, uncooperative, already on BiPAP, 100% FiO2. Saturation is 88 to 92. Airway exam, of course, is not possible. Tachycardic, blood pressure is 140/78. And fasting status is unknown, and labs are grossly within normal limits. And this patient is given propofol, 100 milligram, and rocuronium. An RSI is performed. We use video laryngoscopy, nice grade 1 view. Endotracheal tube passes through the cords, and we get perfect waveform capnography, and we're really happy and good to go. And what do we see next? The patient's next blood pressure is 80/40. End-tidal CO2 drops from 30 to 15. Mephentermine is used at 24 milligram push. Patients become pulseless, and CPR is initiated. Of course, it's not always so dramatic, but I'm sure you have seen profound hypotension following tracheal intubation in intensive care unit. Now, there are several studies, national audits, and multi-center studies that have looked at the incidence, high incidence of complication in critically ill patient. But the Intube study, which was published in JAMA in 2021, and I was very proud to be the second author on this paper, was the first study that looked at how tracheal intubation in the critically ill was performed across the globe, both in high and low income countries, and what was the incidence of complications among these patients. In the interest of time, I will not take you through all the details of the study, but I can just tell you that it included about 3,000 patients, 197 centers across 29 countries. And the primary outcome was to look at least one of the following events occurring within 30 minutes of tracheal intubation. That's either severe hypoxia or cardiac arrest or cardiovascular instability defined by one of the following criteria. And if I just give you a broad snapshot of the primary outcome, if you look at the complications, 45%. That means almost 1 in 2 patients in whom we do a tracheal intubation, a critically ill patient, has one of these complications. And what was a really interesting finding, that it was not hypoxia, but cardiovascular instability. 42% patients had cardiovascular instability. And this is the first time the study really revealed such a high incidence. And hypoxia was only 9.3%. Perhaps over time, we have become good at peri-intubation oxygenation. We're always worried about hypoxia, but the real complication that occurs in critically ill patients is actually hypotension. Cardiac arrest was about 3.1%, and this was consistent with the data from the group of Samir Jaber and Audio de Jong. And one important finding of this study was that this complication had an impact on 28-day mortality. Now, most of the airway studies that look at complications do not look at long-term outcome. This study was the first that showed that patients who experienced an outcome like cardiovascular instability or cardiac arrest actually had a higher risk of 28-day mortality. Now, that's a very important finding because usually when we have this kind of complication, we give a vasopressor or we reoxygenate the patient and we think we're fine. But the occurrence of this complication actually has an impact on 28-day mortality. And that means that we have to actually prevent rather than just treat these kind of complications. Now, I'm an anesthesiologist. I work in the operating room. I work in the intensive care unit. So I'm able to compare airway management in the operating room and in the intensive care unit in the same period of time. And I've always wondered, why are complications related to tracheal intubation so high in the critically ill patients? And in my mind, there are 3 fundamental differences. One is the ICU environment, which is so complicated. The second are the operator factors. These are not the skilled anesthesiologists whose core competency is airway management. You have varied levels of skills. You
have people from different, maybe, it can be pulmonologists, they could be surgeons, they could be from other specialties with various levels of SIDS, and most importantly, even the patients are different. And this is an old photograph, and this is looking at the ICU environment. When I try to get to the head end of the bed, it's itself such a struggle. There's so much clutter around the bed. This is a patient of septic shock. I don't only have to look after the airway, but I also have to look after the hemodynamics. And it's a very, very complex environment that increases the risk of complications in these patients. And most important is it's the patients itself. Now, these are not the stable, fasted patients who come for surgery. These are critically ill patients who often start with an imbalance between oxygen delivery and consumption. There are various factors that increase the consumption, like fever, sepsis, tachypnea. And as we all know very well, the delivery in these patients due to anemia, cardiac output, lung disease, and various other factors can also be compromised. Now, what is the physiologically difficult airway? This is not a new entity. This is described first by Gerard Mosier and John Sackers from the emergency department, and they highlighted the fact that these patients with the altered physiology actually increase the risk. Because of the altered physiology, there was increased risk of complications. But they talked about only critically ill patients, and we thought we should actually try to define this. And we said the physiologically difficult airway is actually an emerging concept. And with my colleague, Dr. Divatia and David Brewster, we tried to, expand this, and we said that it is not only about critically ill patients, but all patients who have physiological and pathophysiological alterations that increase their risk of tracheal complications during tracheal intubation. And we are very happy in the journal Intensive Care Medicine, and Samir Jaber is the editor, to put together this very nice global Delphi on tracheal intubation in critically ill patients with a physiologically difficult airway. And this had more than 50 international experts on airway management in the critically ill who came together to do, and performed a very robust Delphi to give, suggestions on how we could manage this airway, because we realized from various aspects, the data was actually not very strong. And the next best thing that you could do is to have a consensus Delphi among experts. And we have had several expert consensus statements. In the interest of time, I will not be able to go through all of them, but I really urge you to read this article, which was published in the Intensive Care Medicine in October 2024, and it has some really useful contents. But I'll just go through the consensus definitions and also the risk factors. And the definition of a physiologically difficult airway is one in which the patient's physiological and pathophysiological alterations increase the risk of complications during tracheal intubation and transition to positive pressure ventilation. Now, these physiological alterations are often like hypoxia, cardiovascular instability, right ventricular dysfunction, and increased intracranial pressure. A lot of human factor considerations of, for this entity, and the likelihood of encountering them are usually more in the intensive care unit and the emergency department. So by definition, it was not just the pathophysiological alterations that we see in the critically ill, but also the physiological alterations that we see in patients who are obese and pregnant, also that, who have a reduced FRC and have altered physiology that increase the risk of complications. And all along, as anesthesiologists, we are obsessed with anatomical difficulty. We're always looking, even our assessment and scoring systems always look at anatomically difficult airway. But the physiologically difficult airway is something that we often don't consider while intubating these patients. So I'll talk a bit about performing the procedure and post-intubation care. Now, what we had consensus for was a modified rapid sequence intubation. And what we mean by this is titrated administration of rapid onset sedative hypnotic drugs, rapidly acting neuromuscular blocking agents, gentle mask ventilation with or without gentle mask ventilation. This should be considered with these patients with a physiologically difficult airway to prevent peri-intubation complications. Cricoid pressure is controversial, but we said if at all you use it, it should be released, especially when visualization of the vocal cords during tracheal intubation becomes difficult. I won't talk about respiratory support because Professor Jaber is going to be talking to us about this, but I will allude to this recent meta-analysis, from the group of Bram Rochefort from Canada. And this compared all the pre-oxygenation strategies for tracheal intubations in critically ill patients, a systematic review, 15 eligible studies, almost 3,500 patients. And what were the results of this finding? Now, if you look at the forest plot, you can see that high flow nasal oxygen and non-invasive ventilation, it favored this. There's also the combination of non-invasive ventilation and high flow nasal oxygen. Of course, not enough studies, and this comes from the group of Samir Jaber. And the conclusion of this meta-analysis was that pre-oxygenation with either non-invasive ventilation or high-flow nasal oxygen rather than face masks alone might prevent hypoxia during tracheal intubation in adults who are critically ill. Compared to high-flow nasal oxygen, it was non-invasive ventilation probably decreases the incidence of hypoxia during intubation. And this was an important finding of this study. And along with Samir Jaber, we wrote the editorial for this paper, Pre-oxygenation for Tracheal Intubation in Adults who are critically ill, time to abandon the face mask. So perhaps it's time to look at other non-invasive methods of pre-oxygenating this patient for tracheal intubation and, in this high-risk group of patients and abandoning just conventional oxygen therapy. I'll move to cardiovascular collapse. As we saw in the Intube study, 42% of patients had cardiovascular collapse. And this is like a very high incidence. And this is a cartoon from one of our papers. And we looked at the contributing factors and potential solutions. Now, I've often wondered, why do critically ill patients, when they're intubated, have hypotension? So first, it is the critical illness itself, the sepsis, the hypovolemia, the vasoplasia. In addition to this is also the drugs that we use for tracheal intubation, propofol, benzodiazepine. The loss of sympathetic drive is very important, like our patient who had a normal blood pressure. So when they come in acute hypoxemic respiratory failure, they are often tachycardic and they have the hypertensive, and it's the sympathetic drive that keeps their blood pressure up. And the moment you anesthetize them, they have precipitous fall in blood pressure and profound hypotension. And then, of course, the positive pressure ventilation in an already hypovolemic patient after intubation, when you give positive pressure ventilation, you decrease the venous return and further decrease the cardiac output, and this may cause hypotension. So if you look at which is coming with drugs, and all along since the first paper in Lancet that looked at ketamine and etomidate as more cardiostable drugs, there have been several randomized controlled trials using these drugs. And now we have a meta-analysis too, and I'll allude to this one from Yuki Kotani, who's compared ketamine versus etomidate as an induction agent. And there are also other meta-analysis, and this was a Bayesian meta-analysis, and they found a moderate probability that induction with ketamine compared with etomidate for tracheal intubation was associated with improved survival. But studies have showed mixed results. And I would say, taken together, it would mean that you could use either ketamine or etomidate unless contraindicated. Even availability is a concern in certain countries. But what's really important at this is that you should use these cardio-stable drug in these high-risk patients. And I'll tell you why in a minute. Now, this was a paper we published in the Blue Journal, and this was a subgroup analysis of the Intube study. And what we did is we looked at all those patients who had cardiovascular collapse, and we did a multivariate analysis and tried to look at what were the cause of the cardiovascular collapse in these patients. And we had some very interesting findings. And as you can see, the use of propofol for induction was identified as a modifiable significantly associated with cardiovascular instability and collapse. Now, this is a really important finding. And what was even more interesting is that irrespective of the starting blood pressure, propofol independently transitioned to hypotension. And the biggest offenders were actually the anesthesiologists, who looked at airway management in the intensive care unit as an extension of what they do in the operating room. And most of them use propofol, whereas the ED docs and the internal medicine guys use ketamine or etomidate. So this is really an important message, because I remember my practice, I would say, okay, the blood pressure looks fine, so I could use propofol, and the blood pressure is low, patient's in septic shock, so I'll probably use ketamine for this patient. So what else can we do? And we have the lovely intubation bundle from Professor Samir Jaber. We talked about giving 500 ml of saline to prevent cardiovascular collapse. So this is known that critically ill patients have hypotension, but it was never tested in a randomized controlled trial. And this was done by the group from Vanderbilt, led by Jans. And what they did is they did a randomized controlled trial, the PREPARE study, which compared almost 337 patients. And they gave one group of patient 500 ml of saline and the other group of patient no fluid bolus. And the primary endpoint was looking at cardiovascular collapse. And interestingly, the administration of intravenous fluid bolus did not decrease the overall incidence of cardiovascular collapse compared with no fluid bolus. And the same group went ahead and did another study, because what they found was in the subgroup of those patients who received positive pressure ventilation, fluid seemed to be making a difference. And what we mean by positive pressure ventilation is either NIV or gentle mask ventilation during RSI. So they included only these patients, and they did another study, and this was a PREPARE 2 study. And again, in one group, they gave 500 ml of saline prior to tracheal intubation, and in the other group, there was no bolus. But surprise, surprise, no difference in the primary outcome in the incidence of cardiovascular collapse. Of course, there were several limitations in these studies, and in the interest of time, I won't talk to you about. But taken together, it seems that the fluid bolus that we've been, conventionally practicing doesn't seem to make a difference. So hypotension is real. And giving a fluid bolus prior to tracheal intubation doesn't really seem to reduce the incidence of cardiovascular collapse. And there are 2 trials that are underway, and one is the FLUA trial that has just been completed in our unit. And here I'm still not convinced that fluids don't make a difference. And this is comparing fluid bolus versus vasopressors on cardiovascular collapse among critically ill patients. And we've just completed this trial, and we will soon have the results published. And then there's a prevention trial, which is a multi-center trial comparing the effect of low-dose norepinephrine with usual care. This is sponsored by the ESICM. I'm also on the steering committee of these studies. Now, in both these studies, we've used norepinephrine as a vasopressor, started preemptively as a low-dose infusion from a peripheral line. In the FLUA trial, we used 0.08 microgram per kg per minute and continued it until 5 minutes after tracheal intubation, which is the period during which the hypotension is usually seen. And these results of these trials will actually tell us whether there is a role for a low dose of vasopressor prior to tracheal intubation. Very quickly, I'll talk about the tools for tracheal intubation. Video laryngoscopy, let me tell you, was not a very popular tool that was used in the intensive care unit, unlike in the operating room, where clearly the studies had shown benefit. But I think after the device trial, the large, well-powered randomized controlled trial, it's clearly shown the benefits of video laryngoscopy in improving first-pass intubation success. And the important message is we should use laryngoscopy for all intubations as a default, and everyone in all intensive care units should have it, and everyone should be trained to use it. What about other tools like the use of stylet? And this is a very nice study from Professor Jaber, 999 patients, randomized controlled trial comparing the use of stylet in the endotracheal tube during the first attempt at intubation versus no stylet and just using an endotracheal tube. And what did they find? That when you use a stylet during the first attempt at intubation, there was increased first pass intubation success compared to when you don't. And during tracheal intubation, we usually use it as a rescue and not during the first attempt. And this is a really important message from this paper. And what about the use of bougie? And this is again from the Vanderbilt group, bougie versus stylet. And what they found is when either tool was used during the first attempt at intubation, there was not really much difference between the 2 tools. So taken together, I would say that in critically ill patients during tracheal intubation, either a bougie or stylet, whatever you're familiar with, should be used as during the first attempt at intubation to improve first-pass intubation success rather than as an rescue. And the last part of my talk, I'll talk about esophageal intubation during RSI. And people will say, oh, esophageal intubation, that never happens to me. Now, this is from an old study from Mott, even a single episode of an esophageal intubation. And you can look at the different types of complications, and you can look at the incidence when with or without an esophageal intubation, and you can see how significantly high it is when you have a esophageal intubation. And there have been, the important message from this is that use capnography. And, there have been several deaths, 2 deaths in the UK and also in Australia, following which the Puma group, were a group of anesthesiologists, intensivists, and ED doctors who looked at a project for universal management of airway. And we came up very quickly with this guideline for recognizing unrecognized esophageal intubation. It was a consensus guideline that we published in Anaesthesia, a very nice graphic. And we said, look at 7 consistent waveforms without any decline, because even the traces like you see in red are unacceptable. It's not important to just respond to 1 or 2 traces. Often when you have a stormy intubation, a lot of air goes into the stomach. And then when you have an esophageal intubation, you see 1 or 2 traces of capnography, and then you see the decline. So 7 traces of consistent waveform capnography with no decline is really, really important. And it's when I go back to the Intube study, it's really sad to see that video laryngoscopy is only used in 17% of people. And this is not in the developing world where you can say video laryngoscopy was not available. This is also in the developed world. And if you look at how people were confirming tracheal intubation, only 25% were using waveform capnography. Again, the same story, a mix between the developed and developing world. And it was not an issue of availability. It was really an issue of, not having the knowledge about it. And this is 10 years after the National Audit Project, which clearly showed, increased morbidity and mortality following, when capnography was not used. So 10 years after this, also only 1 in 4 patients who are critically ill are being intubated, and and that is being confirmed using waveform capnography. So we really have a lot of work to do if you want to improve into our intubation practices. So my take-home message is the physiologically difficult airway is one in which both pathophysiological and physiological alterations in patients increase the risk of complications during tracheal intubation. And remember, it's hypotension that's more common, and hypoxia following are the most common complications. And there is a higher risk of 28-day mortality when you experience one of these complications. So the goal should be to prevent rather than just treat these. And the strategies that I've outlined may help in the safer management of patients with a physiologically difficult airway. And most importantly, tracheal intubation is a life-saving procedure, but this can turn into a life-threatening situation if it is not managed properly. And with that, I thank you very much for your attention.
Now, may I invite Dr. Jaber?
Ladies and gentlemen, I'm happy to be here with you. Thank you very much for the invitation. Thank you for Dr. Sheila Myatra for the invitation for me. I will present you the non-invasive respiratory in acute hypoxemic respiratory failure. This is my disclosure with no thing with the subject of the presentation. So I propose you to see some background, the rationale of use, the most important non-invasive ventilation tools that was high flow oxygen therapy, the CPAP, and the non-invasive positive ventilation, and some clinical evidence that's available today, and just one or two slides about the bedside application with the main optimal setting, especially for the non-invasive ventilation. First of all, just to remember what are the main ventilation technique and tools today. You have this in the yellow one, you have the airway pressure, the flow in the green one. The first, when you breathe now, you have your flow and your airway pressure at 0. You see here the flow, which is sinusoidal. This is the oxygen standard. And then you have the PEEP. If I put a positive end expiratory pressure at 8 centimeters of water, for example, you have also a sinusoidal flow, which is a physiological flow, which is a CPAP, as you see here. And then when you have two pressure, which called non-invasive ventilation, mainly is pressure support ventilation plus PEEP, you have first pressure, which is end expiratory pressure is, for example, here 8 centimeters, and we have a positive insufflation, which can call also the driving pressure. This is the pressure support at 7 centimeters of water. You have 15 centimeters of water in all of the pressure. But the difference is in this technique, the machines deliver a flow. That you need a machine which deliver here, which called a decelerating flow, which no limitation of the peak of the flow, which helps the patient, and this act as a respiratory muscle, accessory muscles, like a machine, like a muscles. And then now recently we have the high flow oxygen therapy that could be considered not really a CPAP, but a small spontaneous breathing PEEP, which called here, you have a little amount of pressure support PEEP. You see here you have between 2 or 4 centimeters of water, and this decreases when the mouth is open. And the flow is also sinusoidal. We have no help with the machine. So the only technique that you have help with the machine is the non-invasive ventilation. So these are summarized on this slide. As you can see from the left to the right, the severity of the oxygen failure. As you see here, you start with the oxygen cannula. You have the high mask of concentration, you have high flow oxygen, and this when you have a pump failure, you have hypercapnia, and when you have hypercapnia, you need to have ventilation, and ventilation, you need to have non-invasive ventilation with a machine as act like a respiratory muscle, mainly the diaphragm. And then at the end, you should intubate the patient to avoid delay to improve the outcome. The strategy could be summarized like this. You have the curative and prophylactic. Curative is when you have acute respiratory failure is present and the objective is to avoid intubation. And prophylactic or preventive is when acute respiratory failure is not present, but you will apply non-invasive ventilatory support to the patients at high risk to develop acute respiratory failure. And then the objective is to avoid the development of acute respiratory failure. And then you have obviously a gray zone. Sometimes it's not clear if NIV is used for avoid or to prevent acute respiratory failure. And then for each one, you have the three strategies that I told to you, the three tools, high flow, CPAP, and NIV. What are the major difference between both? What could be the major difference between high flow nasal oxygen and non-invasive? As you see on this slide, probably one of the major is the leaks. As you see, you have the leaks around, and the setting is more complex with NIV, and you need to have experience and expertise to have non-invasive ventilation. In contrary, with high flow oxygen therapy, it's very simple to use it. High flow oxygen therapy, it could be used only for the hypoxemic patients or some very moderate hypercapnic patients instead of non-invasive ventilation, which is mandatory when you have hypercapnia or severe hypercapnia. So the main mechanism that you should know about acute respiratory failure is when you have a gas exchange failure or a pump ventilatory failure. So when you have a gas exchange failure, the mainly problem comes from the lungs and is sometimes an isolated hypoxemia, which is my talk of hypoxemic acute respiratory failure. And the treatment is oxygen therapy. Then the objective of the oxygen therapy is to improve PO2 and oxygen saturation. However, when you have a ventilatory pump dysfunction, the muscles, mainly the diaphragm, are injured. So you have an hypoxemia, a small amount of hypoxemia, but you have an hypercapnia. And in this situation, the treatment should be ventilation, that means CO2 removal. Then you need non-invasive ventilation in this case to decrease the PCO2 and to increase the pH. Who benefits from non-invasive and or high-flow nasal oxygen therapy? You have a lot of data today. I try just to summarize in a few minutes. Then today, in comparison to oxygen alone, you have this very relevant meta-analysis, even it was published 10 years ago, when you have the number needed to treat, the NNT, the number needed to treat by non-invasive ventilation to avoid one death is 11 patients. That means it works in hypoxemic respiratory failure patient when it's used in a good team with experience and expertise. This review, systematic review on meta-analysis published in the JAMA a few years ago, I see it compares with these slides. You see the comparison between non-invasive ventilation, oxygen standard, and high-flow oxygen therapy. The main message of this is that non-invasive oxygenation, that means NIV or high-flow oxygen therapy strategies, compared with standard oxygen therapy, were significantly associated with lower risk of death. This is a major message, as you see, and this now we have a lot of data showing this, which is available data. So when you have hypoxemic acute respiratory failure, you should choose probably high-flow oxygen therapy or NIV if you have a good team with good experiences in this case. And then this is one of probably my favorite paper published a few years ago by Lavina Munshi and the past Jordi Mancebo and Laurent Brochard, which is a summary of NIV. And as you can see here, which method is good to use is NIV for COPD and OS and congestive heart failure and exacerbation. And then one message is consider intubation for the more severe acute hypoxemic patient, not too late. This is a very important message of the paper because probably one of the bad things that we do is to wait, and to push too hard the non-invasive ventilation strategy. So in this review, the author suggests to consider the trial with high-flow oxygen therapy or NIV or both together in alternance, one between the trial of NIV applied high-flow oxygen therapy. This is probably one of the major things applied today. In when you have, again, I repeat, when you have, again, the experience and the expertise of your team. You have a skilled team. So finally, which method to use? It's not clearly defined today, and there are other trials, and probably in the real life, you should make a trial and to check if it works or not. And if it works, you can continue, and if it not works, you should intubate the patient. This is my main message of this presentation. Then what's the clinical evidence aujourd'hui of who may benefit of non-invasive ventilatory support today? And this in the paper of the group of Laurent Brochard and Lavina Munchi, they summarize this. You have non-invasive ventilation, cardiogenic pulmonary edema, the COPD patient, chronic obstructive pulmonary disease patients, obesity patients, mild to moderate acute hypoxemic patients. You should probably avoid in the severe. The more severe acute hypoxemic respiratory patient probably should be intubated early. This is probably one of the major message also of this review. Then, as presented by Professor Sheila Myatra, the pre-oxygenation during intubation, we have strong data today to measure. And then we have after surgery, we have strong evidence after surgery to prevent or to treat acute respiratory failure. So the rationale for high flow oxygen therapy is mainly due to the action of this. You have, when you speak about the respiratory system, you have three things. You have the airways, you have the gas exchange, and you have the muscle pump. And then the high flow oxygen therapy, you have an action in the high flow with high FiO2 delivery. You have a PEEP like a CPAP from 2 to 3 centimeters of water when the mouth is open, or more when it's open close, the mouth closed. You have the same on the muscle function. You have probably an effect of the airway pressure of the airway. And you have many, the most important action is the humidification with the heat humidifiers, and then you improve the mucociliary clearance system. You have the dead space washout. This is very well documented today. And then all of this action, when you have an addition, one of each other, you improve this, and then you have a comfort improvement, and you have a decrease of the work of breathing. So you have this summarized in these slides. How it works, the rationale for use non-invasive ventilation, you have mainly the same, but you have an increase of FiO2, a decrease of work of breathing, an increase of minute ventilation, decreased dyspnea and comfort improvement, alveolar recruitment, and maintain patency, and also improve cardiac output. But one of the main is probably you increase the minute ventilation, and then you can have a CO2 removal. So the 5 main message for NIV success is to have the good and the right indication. As we said, surgical postoperative patient, COPD, CPI, and then you could complicate, you should use it in the right indication. You have a good expertise and experience of all the teams and a skilled team. This is very important. You have a correct setting, so you should try to always limit insufflation pressure to avoid the leaks. Limit tidal volume, it's recommended to limit it to 10 milliliters per kilogram. The literature is 9, but 10 is good. And then always please consider expiratory tidal volume, not inspiratory, but expiratory tidal volume. That expiratory tidal volume is the volume which participated to the gas exchange coming from the lungs. And this also avoid volo and barotrauma and avoid the PSILI, the patient self-induced lung injury. The 4 is to have the good material, the good ventilator, especially dedicated to an IV, good interface, good humidification devices, and finally, probably the main message when you speak about hypoxemic acute respiratory failure is when you use non-invasive ventilatory support is to stop early if non-improvement and not to delay intubation. This is really my major message of the presentation. Clinical evidence, I just show you some paper because we have a lot of paper today in this topic. We published a few years ago this trial in hypoxemic acute respiratory failure after surgery, and we reported that we can decrease the rate of intubation using non-invasive ventilation in comparison to oxygen standard therapy As you see in this trial, we decreased from 46 to 33% of intubation. The same was presented also in thoracic surgery by my colleague and friend François Stéphan, which it is a non-inferiority study showing that high-flow oxygen therapy and non-invasive ventilation delivered by a dedicated machine could have the same rate of intubation. This is very important in cardiothoracic surgery. Then the recommendation of the ERS and the ATS is to use non-invasive ventilation after surgery. What is in preventive surgery? In preventive, we have this one old, but from Vincenzo Squadron on Marconi, showing that the CPAP could prevent, this is a prevention, you see, 10% to 1% decrease of rate of intubation. This was not confirmed in this trial using the same design, and then it's may explained by different population and by different way to use the CPAP. So I show you some slides of how it works NIV. This is a CT scan obtained before NIV, and this is after NIV. You see just one trial of NIV. You have a recruitment, and then when you make it in a software with 3 dimensions, you see here in the red part is atelectasis, and the green part is a good, normally aerated lungs, and you see before and after, you have a difference. This is the responder patients, and now we have similar trial, which I will present in the Munich in the few days in the Congress, showing the same thing with high flow oxygen therapy. We have the concept of responder and non-responder. That means it not works, and this may explain the difference between the patients. This is the last trial that we published recently, showing that we can prevent with using non-invasive ventilation in the obese patient after extubation, and then it's better than oxygen standard. So I think this is the main setting. As you see, you can have the slides after you see the slides. So my major take-home message in that you can use it in post-operative, as we are all of us probably anesthesiologists and intensivists. Always eliminate a surgical complication before to use NIV. This is very important. And you can use high flow and or NIV both together in alternance, but you never should delay the intubation. If the patient improve, you can follow. If the patient not improve, you should stop. Thank you very much for your attention.
Thank you so much to all of our wonderful speakers. If I can please ask those who are not speaking to mute. Thanks so much. We have a lot of amazing questions from our learners, and I would like to start with Dr. Bernd, since I know you have to go speak to Parliament. But one of the questions from our audience is, for how long do you perform CPR?
You perform CPR until you have return of spontaneous circulation. And the recommendations differ. Some say at least for 30 minutes, and some say for longer. It depends on the local settings, I would say. But I personally know also people who were stabilized after 2 or 3 hours of cardiopulmonary resuscitation, particularly, for example, in case of pulmonary embolism. In case of pulmonary embolism, we suggest using a thrombolytic agent during CPR, and you need to give this agent time to solve the thrombi. So the recommendations of the European Resuscitation Council is, at least in such a case, to resuscitate for 60 to 90 minutes if you don't have return of spontaneous circulation before. And you need to make an individual decision in a young patient with a good prognosis. I would maybe after 45 or 50 minutes think whether he or she should go on ECMO, for example, if you have ECMO available, but don't give up too early. That is my statement.
So it sounds like there are different numbers and maybe not one consensus about at least 30 minutes or at least 20 minutes. It's maybe some considerations about the patients. Is that fair?
That is fair. And we don't have any specific numbers in our guidelines when to stop. It's always an individual decision. So if you have an unwitnessed cardiac arrest with an asystole in a 90-year-old, you will probably not necessarily decide to do 3 hours of CPR. But if you have a witnessed arrest in a 30-year-old lady who probably has a pulmonary embolism because she's smoking and take the pill, I would never give up, even not after 2 or 3 hours. So, and in between, everything is possible, I would say.
From your perspective, Dr. Bernd, what are the most effective strategies for training large numbers of individuals to perform high quality CPR, for example, in a health emergency, such as a natural disaster or an outbreak?
That's a difficult question. It also depends on the local setting or on the country or the region, I would say. I mean, with this kind of virtual interactions, we have a lot of possibilities. We can do webinars, we can do social media activities. And the most important thing for me is to really see that people are doing thoracic compressions deep enough. In most of the cases, they are not doing it deep enough, not only lay people, but also professionals. Even if you are looking to television, in most of the cases, not deep enough. And I'm always telling them, do what you can. You cannot really compress too hard. If you have rib fractures, that's a good signal because then you have a good perfusion of the brain. And we know the deeper you are pressing, the better is the brain perfusion and the better is the overall survival. And 5 to 6 centimeters is what you need to do, and that is hard work.
I would give the advice to all of our learners not to use television as a guide to how we perform our medical procedures. This question
that does not only apply for medical issues, maybe also for some other political issues.
I agree with you 100%. This next question is really for all of our panelists and all of our speakers, because I think all three of you have touched on this issue to some extent. So when we are resuscitating patients, is it better to do an endotracheal intubation or bag mask ventilation, or perhaps Dr. Samir would advocate for high flow oxygen therapy? How do we determine during an acute resuscitation, how do we manage those airways and how do we manage oxygenation and ventilation? We'll start with you, Dr. Bernd, since you have to leave early.
The clear message is do what you can do best. It does not make sense to do a tracheal intubation if you are not familiar with it. And we know that you need to have at least 150 endotracheal intubations until you have a 90-95% success rate. And I have shown you a study that even back valve mask ventilation is extremely difficult. In America, the paramedics are only able to apply 12 ventilations in the good group in 10 minutes. So that is much too less. And in this situation, maybe a laryngeal mask, maybe an ideal laryngeal mask, maybe this will be recommended in the new guidelines, is the best option because the learning curve for an ideal is much better than for endotracheal intubation. You only need 30 to 40 to have 95% success. And it's probably easier to ventilate a patient with a laryngeal mask than with a back mask. So that's my message. Do what you can do best and try to be trained not only on mannequins, but also in real people in the OR, because this is much different as compared to mannequins.
Dr. Sheila.
Yeah, if I may add, I agree with that. We are obsessed sometimes with intubation. Remember, not intubating will not kill the patient. It's not oxygenating. So whatever means, as Professor Böttiger said, you can use it to ventilate the patient and oxygenate the patient at all times.
I need to leave now. Sorry, I need to leave because I'm training the members of the parliament. They just asked me. So thank you very much. World Anesthesia Day today, World Restart a Heart Day today. Great success. Thank you for inviting me. Bye-bye.
Dankeschön. Dr. Faye.
Hey, and I just want to emphasize that in children, I'd agree with his approach as well. I think oftentimes some of our anesthesiologists aren't as comfortable intubating small children. And I would say, make sure your trainees, make sure everybody learns how to bag mask ventilate. It can save a life. 100%. But I also agree with him if your your bagging skills are not great, sometimes placing an LMA might even be easier. And I would probably tell someone who isn't well versed in intubating to do that first. Oxygenation is key.
I would imagine, I mean, you're all mentioning the skill set of the providers that are responding to the resuscitation. And I'm guessing that it has to do with not only the skill set of the responder, but also the setting in which they're responding. So if this is an outpatient community resuscitation versus in an in-hospital setting. Dr. Samir, can you comment a little bit about the use of high flow oxygen therapy or non-invasive ventilation in these settings?
Yes, thank you for the question. I think the major issue is to maintain oxygenation, is to deliver oxygenation. What you can do, please, is the first thing to do is to oxygenation. So it depends on when you are, if you are in the ward, if you are outside the hospital, it depends. So deliver oxygen. If you have oxygen bends, you open the bottle at the maximum that you can, and then talk to the help. You need to the help to, and then obviously as soon as possible, it's possible you intubate the patient, but waiting the moment to intubate the patient, you should deliver the maximum oxygen. If you have high flow oxygen therapy, please put it oxygen therapy at the maximum that you have. If you have more than 16 or 17 liter, you can deliver, because we know today that oxygen is the most important thing in the 2 or 3 minutes before intubation. This is my major message, I think.
Merci. Dr. Sheila, we spoke a little bit about the preemptive use of oxygen prior to managing the airway, but also you touched a little bit on preemptive use of vasopressors or inotropic support for patients, especially if they are critically ill, which I would argue most people being intubated are probably critically ill, unless it's in a surgical setting or procedure setting. Do you have any recommendations for those who are trying to choose hemodynamic support for patients prior to a physiologically challenging airway?
Right. Thank you for this question. Very relevant. So we really don't have the answer. And in both these trials, we're using norepinephrine. We do need to compare the different vasopressors, but we're not there yet. We still have to find out whether there is a role for the preemptive use of vasopressors. And it's not so simple, because when you have to use a low dose, and even determining what should be that dose is challenging, because you have the pressor response of laryngoscopy and intubation, and even along with the vasopressor, this can actually cause hypertension. So you have to use a bit, but not too much. So we still have to define, when to start, how much to use, and of course, as you said, which is the best of the vasopressors. A lot of people also give push dose vasopressors. So there are different practices, but we don't have the evidence yet to say that one approach is superior to the other.
Okay.
Maybe I can complete the answer of Sheila. I'm absolutely agree with Sheila, and I want to say that the papers that shows negative results, they compared only fluid bolus or only vasopressor. Our recommendation is to use both together. This is totally different. Is to use both. That means you use the fluid bolus plus vasopressor, mainly noradrenaline associated. And this it should be used in every patient, even the patient with flow or not. And this we don't have now a randomized control trial. We are starting one called pressure and tube, which is the new one. When in this study we compare the both together versus the other one alone. That's why the study are probably negative. This is one of explanation, this negative study. And in these studies that published, a lot of patients have been excluded. This may also explain why we don't have a negative result. This is one explanation. And we are waiting for the results of the next study. I don't know if Sheila can give us some data, or I think no, I'm not sure.
Well, I can't reveal the results, but I just want to make a point that I completely agree with you, Samir. It cannot be one or the other. And what we have done is both the patients have received fluids. And then we've randomized them to either getting just 500 mils of fluid prior to intubation or vasopressor. It can never be one or the other. And one of the important limitations of the PREPARE trial was they looked at cardiovascular collapse 2 minutes after tracheal intubation. And I would say this is not an appropriate timing because we know that the pressor response to laryngoscopy is going to keep that blood pressure up. So usually the fall, the hypotension should be looked up, the primary endpoint should be at least at 5 minutes. So I'm not convinced that fluids really don't work. So perhaps the results of these 3 trials will give us the real answer, but it's a really important clinical question, thing that we need to know because the incidence of hypotension is very high in this group of patients.
Can I make a point here? So just because the trials are negative doesn't mean that there aren't patients who are benefiting from both pressors and fluids. It just means that the trials enrolled patients who benefited and patients who were harmed, and the average was no signal. So clearly there's room to use fluids and pressors prior to intubation to avoid hypotension. A smart anesthesiologist will probably know which patients those are. And the lack of a positive, quote unquote, clinical trial does not mean that we shouldn't be doing it. And no clinician should walk away reading those trials and say, oops, never going to give pressors or fluids.
My next question is for Dr. Suneerat. Thank you for joining us from Thailand. When you and your colleagues work across both the urban and rural settings, how do you balance implementing international guidelines with local realities such as workforce shortages, geography, health system structure? How do you manage those things during health emergencies and crises?
Yeah, in Thailand, they are different from other countries. We have village healthcare worker in every village in my country. So, and we train them, and we have some salary for them and some incentive for them, and they have to come into the local hospital and then to the center, and they have to train, and some of our doctors from the local hospital we go out to train them also. So it kind of we check them in and out to make sure that they did the right thing, especially when they do the CPR. They need to place on the right location, and for ventilations, we also tell them that we help ventilate, but not too much, and that urbans that they all agree with us, and it helped very well in our country. It's going to every villages, even in the border between Thai and Cambodia also, that we have that kind of worker right now that help with the patient and the soldiers.
That's wonderful. Yeah, I think education and training and specifically simulating health emergencies ahead of time before they occur is helpful in almost every setting. There's another question from the audience, again about non-invasive ventilation. However, I'm going to ask Dr. Daniel and Dr. Faye to answer this one because the question is about how do you manage non-invasive ventilation when you're taking care of a pediatrics patient? Are there differences and other considerations that we should have?
I think probably what is going to depend on is the setting where you are working. If you are in a location where you could use and you have access to something like dexamethasone, which you can safely put somebody on an infusion and give a low dose if the child's unable to tolerate the non-invasive, then that might be something you can use. But I will say that if you don't have the ability to do that, that is one of the challenges because you need to think about how to manage the sedation in a setting where you don't want to cause more problems by sedating the child where they can't be properly monitored. So I think that, yes, that can be one of the limitations of being able to use non-invasive in a child. Hopefully that answers the question.
Yes, thank you. How about in the obese patient? And any of our panelists are welcome to answer this. The obese patient with non-invasive ventilation, are there other considerations?
probably the obese patient is probably the main and the best candidate for non-invasive ventilation, as the lungs and the adiposity of the obese patient, you need to have pressure. High flow oxygen alone don't deliver high pressure. So you need high pressure to open the lungs. And this, for the obese patient, we showed in the X-tube obese study and the post-hoc analysis that the patient with obesity may benefit from non-invasive ventilation after extubation or to prevent intubation.
Yeah, I also agree with him because in my ICU we did a lot of like laparoscopic gastrectomy, and then it looked like a balloon that after extubation we put them on the non-invasive ventilation, and just for the high flow we did it later on after the non-invasive, and we trained the patient to breathe in and out with a high flow after the non-invasive.
There are a couple, there's more than one question in the Q&A from our participants asking, what if the patient is struggling with the mask, an agitated patient who's unable to tolerate? What are some of the strategies that the speakers and panelists might use for that patient?
I think when you have agitation with your patients, you should really consider if a good indication of non-invasive ventilation. In my point of view, when you have agitation, etc., it's a non-indication of non-invasive ventilation, and you should consider early intubate the patient. This is my position in the real life. It's one probably of the best surrogate to say that this patient will be a failure.
Thank you so much. The next question I'd like to ask to my intensivist colleague, Dr. Sheila, and it might have been a question for Bernd, but since he's gone, we'll do our best to offer our perspectives. What is the role of CPR and resuscitation in a patient with really refractory septic shock on multiple vasopressors? How would you manage that patient with CPR?
Sorry, I didn't understand. A patient in septic shock with multiple vasopressors and continuing CPR? Yeah, that can...
Exactly, yes, yeah. What is the role of CPR in patients with cardiac arrest due to refractory septic shock on maximal vasopressors?
Right, so that can be really challenging, and chest compression, CPR may not really work. So this is the kind of patient that if you have ECMO, you should try to put this patient on ECMO if it is possible, because if you're refractory to the vasopressors and the other strategies and you don't have reversible causes that you can correct immediately, then this can be quite a challenge.
Yeah. What maybe for the whole group, in what situations would we recommend ECMO for patients who have cardiac arrest? Maybe for adults and for children.
We have trained a lot of ECMO in my institute, and we tell them that have to pick the right patients, the patient who have the good prognosis. And if you want to put it in, you have to put it in very early, because if you put it in late, you will not have a chance. But anyhow, for the septic patients, septic shock patient, the outcome of the ECMO is not good. Except when the patient have severe hypoxemia, we do the VV ECMO, or cardiac failure, we do the VA ECMO. But just for the septic shock, it's not good. But ECMO is a good choice.
Go ahead, Faye.
Hey, I would just say in our hospital, which definitely I would perceive as saying is incredibly well resourced, ECMO, I'd say no child probably who arrest and we can't get return of spontaneous ventilation would not go to ECMO prior to stopping CPR unless it's a terminal illness for some reason. So we use it incredibly aggressively. I don't know if that's a practical solution for most areas of the world, but that is something I will say we do here.
Thank you. I want to shift gears just a little bit, and Dr. Daniel, I'm going to pick on you a bit. As the chair of your department, you're in a leadership position in your health system. What are some of the system's considerations and approaches to managing large health emergencies, such as a pandemic or maybe a natural disaster or an armed conflict? Do you have things that you think about when you're running your department and your health system in regards to resource allocation and workforce?
Sure. So, of course, we are lucky or unlucky that we have an excellent example from 5 years ago of exactly such a scenario. And all of us as anesthesiologists will remember that although we're often forgotten in the day-to-day and considered something that just, exists in the OR, when the shit hit the fan, everybody wanted more anesthesiologists and more people, and we were able to step up and provide the resources to essentially save our hospitals. So when Beth Israel needed to triple its mechanical ventilation capacity in 1 month, it was only because of anesthesiologists. So our role is central, and we should be participating in planning, and we have the resources and the reserves to take care of dozens of extra patients, and that's the manpower. It's the ventilators, because all of our anesthesia machines now are sophisticated enough to take care of relatively sick patients. It's the infusion pumps, the monitors, everything that goes with it in our holding areas, our PACUs, and our operating rooms. So I view us as really being core to any response to a natural disaster, to an infectious disease outbreak, to armed conflict, which unfortunately is, becoming relatively common in our world. So we need to step up, take ownership, and really show our value in these unusual events.
Thank you so much. I could not agree more. I think anesthesiologists certainly have the skill set, not only in the operating theaters, but also with workflows and moving patients around the hospital. We're kind of multidisciplinary as anesthesiologists and as intensivists. Any other comments about systems or other final thoughts about health emergencies and our role as anesthesiologists from our lovely group of panelists and speakers?
Anna, I just want to highlight something that I was going to bring up, but it didn't come up, and I tried to put it in the chat, just because I know so many folks are always don't get as much experience taking care of children. Just to make them aware, there's an amazing resource out there that's free that was put together by the Society for Pediatric Anesthesia. It's the Critical Events Checklist, and it's actually in multiple languages. And there's now an app both on the Google Store and on Apple that I would highly recommend you put on your phone in case you do have some type of critical event with a child and you just want to review the protocols, because it's not something you see all the time. And I'd make sure your trainees have it. It's just an amazing resource I want to make sure folks can take away with.
Wonderful. Thank you. There was one more question that I'll just address before we close, as we are at time. And that is, how can we, as learners and anesthesiologists across the globe, how can the WFSA help us in managing health emergencies in our day-to-day care of patients? There are many, many resources on the WFSA website with our anesthesia tutorial of the weeks. We have a YouTube channel with all of these webinars that are recorded and posted on YouTube. Additionally, there are multiple short courses that the WFSA has either directly developed and or sponsored, such as the SAFE courses for obstetrics and pediatrics. So I would encourage all of you to go to the WFSA website and explore all the wonderful resources that are available to all of you. And once again, I just want to extend so much gratitude to our speakers, excellent talks, to my co-moderators and co-hosts and our wonderful panel. And with that, I'll turn it back to you, Elizabeth Thompson.
Great, thank you, Anna. We just have one closing video to play, and then we will send you off to the rest of your day.